Hello, I'm back. Okay, so today what we're going to do is this series is going to be the second half of the neuro stuff. We're going to start with chapter 61, which is going to talk about neurotrauma. When you think about neurotrauma, you either have brain injury, something that affects the head, or a spinal cord injury. So those are the two things that we're going to talk about. So let's start out on page 1995, chapter 68, Managing Patients with Neurotrauma. Couple things I want you to be familiar with in the glossary. I want you to be familiar with the word autonomic dysreflexia. That relates to spinal cord injury patients, so I'm going to explain more about that in the second half of this. You do need to know kind of the difference between concussion and contusion, just because those are so common, and you'll see it a lot in your practice. Everybody and their brother has concussions, and there's a lot of talk about it now in preventing and the management of concussions. So I want you to know about that. And that's sort of it with the glossary. Just make sure you know those words. All right, so let's start with head injuries. Head injury is basically any blow to the brain. And it can be resulting from anything: motor vehicle accident, a lot of sports. A lot of our veterans and military guys are coming back having received some kind of shrapnel or, blunt force trauma to the head. So all kinds of things can cause a head injury. You need to know the difference between the primary injury and the secondary injury. The primary injury is the actual impact. So like if you get hit right here, that's the primary injury. But secondary injury can occur because of shearing forces, because of hypoxia, because of increased intracranial pressure. All the things that follow the initial primary injury are considered the secondary injury. And you can't overlook the secondary injury things because they can create just as much problems if you're not managing them as a nurse. So read through a little bit of the pathophysiology about that. I love this figure 68.1 on page 1996 about the physiology and pathophysiology of what actually occurs in a head injury. The thing that you have to keep in mind with a head injury, and I know we talked about this during when we were talking about cerebrovascular accidents, is the Monroe-Kelly doctrine or hypothesis still occurs here, where you only have three components in the brain. You've got the brain tissue, cerebrospinal fluid, and the blood vessels, and those three work in concert to make sure that the brain maintains equilibrium. Well, when something happens to the brain, such as an injury that leads to inflammation, bleeding, hypoxia, decreased cerebral perfusion pressure, ischemia, any of those things can now cause increased intracranial pressure and make the problem a lot worse. So you as a nurse have to manage those things, and time is always of the essence when you're dealing with head injury. The most important thing I want you to be cognizant of in brain injury is management following it. So step one, you have to make sure they also don't have a cervical injury. And I'm going to talk a little bit more about how to determine that when we get to spinal cord injury. But like the nature of the injury, if you ever suspect that there's also a cervical injury, you maintain cervical alignment, you put them in a collar, because you don't also want to compound a head injury with a spinal cord injury. So we're just going to talk about head injuries first. And we know that there's not also a spinal cord injury associated with it. So when your patient has a head injury, let's say that it's just a concussion. And this is starting on page 1998, describes what a concussion is. Basically, a concussion is a blow to the head that jars the brain, and it results in like diffuse but microscopic injury to the brain. So it's not necessarily going to show up on a CAT scan or an MRI because it's very diffuse, very microscopic, but you might have a lot of little tiny microscopic bleeding. They've done an awful lot of research now to look at people who have sustained a lot of concussions over the years, and they're finding that later in life they are having significant problems with motor skills, cognitive skills, memory, things like that because of the years of microscopic injury, which aren't necessarily showing up on, an MRI. So this is why there's such a push now for better helmets, pre-concussion testing in kids who are doing sports and professional athletes. Most schools have a rule now that if a athlete has sustained 3 or more concussions in the period of a year, they're no longer allowed to play contact sports like hockey and football, sometimes lacrosse, things like that. So following a concussion, if a person takes a force trauma to the head, they may or may not lose consciousness, but you have to assume that they have sustained a concussion. Some classic signs and symptoms of concussion are headache is the classic one, but then the worse the concussion gets, they may also experience some things like nausea, vomiting, photophobia, confusion, lethargy. Those are an indication that the concussion is more severe. The treatment is reduce the metabolic activity of that brain, and you do that by the things we talked about in earlier chapters. Minimize stimuli, so you want a dark room, you don't want a lot of activity, keep the patient calm, keep them quiet, make sure they're not developing a fever, make sure they're not overstimulated. I think I told you guys that I volunteer at a camp in the summers, and it's great, it's a lot of fun, but every single year I'm dealing with concussion. Somebody fell off a horse, somebody ran into each other doing, crud wars or something like that. So I'm taking care of concussions in the infirmary. And most of the employees there are college students. So you get somebody who has a bunch of friends and they've sustained an injury. Well, then what does everybody want to do? They want to come visit the person who has sustained the injury because they think they're being nice. But it's really, really hard to manage all of those well-wishers who want to come see this person when that person just really needs to stay calm and quiet, and they really should just sleep for at least a week, and sometimes depending on how bad it is, they require just a quiet sleeping environment for sometimes 6 to 8 weeks to really allow that brain some time to heal. So that is a concussion. A contusion is basically a concussion that's even worse. The patient will lose consciousness in a contusion. That is more significant bleeding on the brain. Treatment's the same usually, just extended more. Make sure they have oxygen, and sometimes you have to give them sedation to because you really want to depress the metabolism in the brain. Now I want to move into intracranial hemorrhaging. Sometimes when somebody sustains a head injury, it is so significant that it can cause bleeding. This becomes a much worse problem than just a concussion. There's a couple different kinds of bleedings, and you do need to be familiar with these. So it starts on like the bottom of page 1998. And there's a great picture in figure 68.3 that shows the different kinds of bleeding that can occur in the brain. This is often following a pretty significant blow to the head, a fall from a high place, a pretty significant car accident, something like that. You don't usually see this kind of injury from like like 2 football guys going at each other. You usually don't see it like that. But a subdural hematoma is often the result of like a shearing. So you remember your brain is sitting inside the skull. If it takes a hit to one side of the head, that causes if this is the skull and the brain is in here, it causes that brain to do kind of this motion. When all those blood vessels in there can get sheared off like that, and it can cause bleeding that can lead to a subdural hematoma. If the bleeding occurs on the top of the dura, it's called an epidural hematoma. Both of them are bad. Epidural tends to be significantly worse than a subdural hematoma because in a subdural hematoma, some of the bleeding can kind of press down into the actual brain tissue itself, and some of the brain tissue can start absorbing that. In an epidural hematoma, it doesn't do that because it's between the skull and the dura, and there's not as much space for it to go, so the dura starts pushing into the brain tissue, and it can lead to much higher intracranial pressures faster than a subdural hematoma. Neither one is great, but if you have to have a bleed, you're going to want the subdural versus the epidural. If you can get the patient with a suspected epidural hematoma, This will occur quickly. The epidural hematoma symptoms start occurring very rapidly following the initial injury. Subdural hematomas tend to take a little bit more time, just because there's more room for the brain to compress before you start seeing symptoms. So if you see a very sudden increase in loss of consciousness, inability to respond, that kind of thing, you can suspect that it might be an epidural hematoma. The treatment of choice is you got to get them to surgery, because there's no way to get that to stop. So one, you hope the patient has not been on anticoagulant therapies. If they are on anticoagulant therapies, you have a bigger problem on your hand. Like if they've been on long-term Coumadin or aspirin or something, same with a subdural hematoma. But you want to get them to surgery as fast as you can, and they will put a burr hole in the skull and then put a drain in to try to evacuate that hematoma that is developing in order to get the pressure off the brain. Same thing with the subdural hematoma. They can put a subdural catheter in and drain out the hematoma if it's big enough. Sometimes if it's small enough and the patient's healthy, the patient hasn't been on anticoags, you can just do conservative management. But in both of these cases, usually surgery is the treatment of choice. And then all the other things that we do for our neuro patients: head of the bed up 30 degrees, quiet room, keep them on sedatives, limit visitors. And then once they get those catheters in, then you have to monitor also for infection, because you've got a catheter going into the brain. Look at the one where they have the intracerebral hematoma on figure 6-8-3. Intracerebral hematomas are not super common from the initial impact of the injury itself. Intracerebral hematomas can occur if an aneurysm ruptures, if somebody has an angioma or an arterial venous malformation. And remember back in the section where we were talking about the cerebral vascular accidents, and I showed you my daughter has that AVM on her hand. Those can occur in the brain, and they're very fragile vessels. And so sometimes in somebody who has a pre-existing angioma or aneurysm or something like that, and then they sustain a head injury, that can cause that to rupture. Or if they have an aneurysm that ruptures, that's also considered an intracerebral hematoma. And you can treat those the same way. If it's an aneurysm, they can go in and do a clipping or a wrapping like we talked about before. And if it's an angioma, you know, sometimes they can't operate on it. You know, like my daughter, they can't operate on that, so you just hope that it doesn't rupture. And if it does, then you hope the bleeding stops, and then you can evacuate it again in surgery with a drain. So those are some things that you need to be careful of in your patients who sustain a head injury followed by a bleed, or have a bleed because of an angioma or an aneurysm or an AVM in their head. Okay, so then following a head injury, and if it is just the edema or if it's the bleeding that occurs, we still have the same compounding factors of increased intracranial pressure. That's really what we worry about, is that increased intracranial pressure rising too much. And so some of that's your goal as a nurse, is to minimize the rising increased intracranial pressure. You want to keep fevers down, because fevers increase metabolic demand. So you check the fever, the temperature in your patient often. You maintain airway. They are often at high risk for nutritional imbalances. They tend to have a lot of sodium imbalances and potassium imbalances, so keep an eye on that. Anybody who sustained an injury, they are going to have an increased metabolic demand, because it requires calories to impair or improve anything. So anytime your patient comes in after any kind of physiological event, you make sure that they're getting adequate nutrition. Oftentimes our patients are undernourished, because that's not the first thing we think about. If a patient is in pain at all, it'll increase their brain metabolism, so you want to keep the pain levels down. I do want you to be familiar with the Glasgow Coma Scale. This is on in chart 68.3 on page 2001 of your book. I was looking for this. I knew it had to be in here when we were talking about cerebrovascular accidents. This is your classic Glasgow Coma Scale. A normal and healthy person should be able to get a 15 on the Glasgow Coma Scale, but 3 is if you get a 3, that means you're getting like 1s on all of those things. That's an ominous sign. If somebody is scoring 1 and all that, they're probably pretty close to brain death. So be familiar with that. I did want to talk about brain death. So sometimes in your patient who has sustained a pretty significant head injury and the swelling is getting so much and you can't help it by the normal things like keeping their carbon dioxide low, keeping their oxygen high, putting them on osmotic diuretics to pull pressure out of the brain tissue. Sometimes your patient is going to be brain dead. And these are the patients, while it's very tragic, they are the patients that are ideal to be the organ donors because they are oftentimes healthy people. They're usually young people who've been able to be out skiing or driving or at a football game, something like that. So they're healthy and they've sustained a life-altering injury that is now causing their brain to die, basically. Basically, it's brain death. But you have to establish that somebody has brain death prior to discussing organ procurement with them. And this becomes a nursing responsibility in concert with the physicians. You're not the one to say, oh, your loved one is brain dead, but you start watching for signs that brain death may be occurring. First of all, remember when a couple, I can't remember which chapter we talked about it, but you know, there's a tentorium, so most of your brain is the skull, and at the bottom, the brain right underneath the skull, and then there's a tentorium that's kind of like this lining that just sort of sits down right above the brain stem. And when the pressure gets so heavy, and it's called herniation, so the brain is swollen, and finally just presses right down on top of that brain stem. The pupils will blow, and then when brain death actually occurs, there's an absence of brainstem reflexes. And your brainstem reflexes are your basic life reflexes. So for example, this is why like your respirations, those will stop. Your heart will continue to beat. Respirations stop. The patient will always be in a coma, and yeah, that's it. Yeah, so there's 3 criteria for brain death. Apnea, meaning they don't breathe. They will be in a coma. And there's loss of brainstem reflexes. And there's a couple ways to figure this out. First, if you suspect that a patient has herniated their brain and they are now brain dead, their heart will still beat. They have to be on a ventilator to keep respirations going. But one thing you do is you stop the ventilator and wait a couple minutes to see if they breathe. If they don't, that's the apnea. So now they have been considered apnea. You take them off any neurological suppressant medications, any sedatives, to make sure that they still are in a coma. And then you test their reflexes. For example, one of them is your corneal stimulation. In somebody who has a functioning brainstem reflex, if you just touch their cornea with a light piece of cotton, they'll blink. That's an automatic brainstem reflex, is a corneal response. Another one is the doll rolling eyes. Like in a normal person, you can roll their head and their eyes won't follow. It's like like how the baby dolls do that. And also sometimes they can put ice water in the ear, and in a normal person, if you put ice water in one ear, your eyes will deviate, and in a person who has no brainstem functioning, that won't occur. So in your patients who you've suspected are now brain dead, because of high increased intracranial pressure that you can't fix, then there are places that you can call and you can talk to the family member about, has your loved one considered donating organs? And there's, like in Michigan, it's called OPAM, the Organ Procurement Agency of Michigan. When you have a patient, and they'll all be in the ICU because they have to be on a ventilator, and they're usually on a bunch of drips, and then, then they go, if the family member says, yes, I'd like to donate, then you can call in OPAM, and then OPAM will take over, and they'll figure out from the registry who needs what. And oftentimes the organs, if they have healthy organs, those can start being, you know, harvested and sent to living people who actually need them. So it's sad on one case because you got somebody who is dying, but happy in another way that you know, the patient could potentially be saving a lot of lives. So so kind of know a little bit about brain death. If you look on page 2002, figure 68.5, this is how you do a neuro assessment. You got, you know, make sure that you're getting their vital signs, because we've talked about the Monroe-Kelly doctrine and Cushing's triad, so you want to assess for that. Like up on figure A, she's checking pupillary response. And when you're doing the Glasgow Coma Scale, you ask somebody, can you squeeze my fingers? And you're measuring strength, but you're also measuring, can that person understand and respond to what I'm saying? If they can't, then sometimes you have to use noxious stimuli, and oftentimes that's nail bed compression. That you just, usually we take a pen light, or, you know, you can just use your own fingernail, but you just take it like this and go like that on your patient. And if do it on yourself, it doesn't cause permanent damage, but it hurts enough that in a person who has a functioning brainstem, they'll pull back from that. So that's how you would do your neuro assessment. And it's somebody who has sustained edema in their brain. Those activities are going to go less and less down the coma scale, all the way down to brainstem. So your goal as a nurse is to keep them towards that 15 number on the Glasgow Coma Scale. Because the Glasgow Coma Scale is the most sensitive indicator of a person's neurofunctioning, so make sure that you're familiar with that. And you remember Cushing's triad. I talked about this before, but just in case you've forgotten, it's when the person gets bradycardic, their heart rate starts slowing down, their blood pressure starts increasing, and they start having, they're not breathing as quickly with a widening pulse pressure. So that's your Cushing's triad. The other thing you want to keep in mind is to keep that temperature down, because your temperature is controlled in the hypothalamus, and when the temperature goes up, that increases metabolic activity. So make sure your patient is, one, that you're checking the temperature a lot, and that you are giving them antipyretics to keep that temperature down. If it's related to an infection, so if your patient has a breathing tube in, or they have intracranial monitoring devices in, those are prone for infection. So if that's the case, and there's something starting to get infected, culture it and get them on antibiotics right away if they're starting to develop an infection related to you treating them for their head injury. Okay. The other thing that you do need to do in this acute phase is you automatically have to start thinking about the rehabilitative phase, because when somebody sustains a head injury, depending on the severity of it, they could have long-term sequelae from that, and you want to be thinking about, how am I going to help the rehab team, how am I going to help the home health care nurses, and this patient achieve optimal functioning once they're out of this acute phase. And one of the easy ones is to prevent contractures, because there's this disuse syndrome. So if you don't use your muscles in your bodies, you'll start having this disuse syndrome, which is basically a wasting of muscles, and they can start developing contractures. And I think I saw a really good picture in here. Yeah, it's in the spinal cord injury section, but I wanted to draw it to your attention right now. It's on page 2014 in figure 68.7. Look at that picture. This is a person who's in a halotraction and a specialty bed and on a ventilator in the ICU. However, I can tell by looking at this picture, this is not a new injury, because look at his hands. This patient's hands are already contracting up. That's disuse syndrome, and that can be prevented. So nurses, even at the very beginning, need to do lots of range of motion, consult physical therapy, occupational therapy. That patient should be on range of motion a lot, and then even once they get home, their families should be taught to do that, because if they're not moving, they will lose it and they will start contracting. So be cognizant of that. Skin integrity, really important, especially if your patient's in a coma or a semi-comatose state. They have to be moving every 2 hours, even if they're up in a wheelchair. We see this all the time. And some of the work that I do with engineers is with these spinal cord injured patients, and they have massive decubitus ulcers because they're home. They don't have a caretaker. They're taking care of themselves, and they forget to get up. They forget to reposition, especially the paraplegics who are able to move up, and they should be doing push-ups with their arms or shifting their body weights, and they forget just because they have no sensation anymore, and they develop ulcers. So it's really important as a nurse to prevent skin ulcers. It's important to prevent other infections, like your bowel and bladder infections, more common with spinal cord injuries. But you always have to be thinking about, once you get your patient through the acute phase of the injury, then what? Because now we don't want to get them through the acute phase and all of a sudden they have, like, here's another one, is when they're laying in bed for too long, they're prone to get DVT. So we want to make sure, if they don't have a bleed, if it's just increased intracranial pressure, you might want to put them on anticoags, or compression devices. Make sure they have like those compression devices on their legs, or TED hose on, because you want to prevent pooling in their veins, because you want to prevent blood clots. So every single one of these things you want to be aware of when you're taking care of somebody who has sustained a head injury, especially the ones that are going to be bedridden or in a wheelchair for a while. Okay, so then, another thing I want you to be aware of is anybody who has had a head injury is at risk for developing seizures. This can occur right away, like within the first 24 hours. It can occur in the intermediate phase, which would be like up to a week following the injury, or any time after that. Any time for the rest of their life, they are at higher risk for a seizure than somebody who hasn't had a head injury. So you always watch for that. You're going to want to teach your patients about that, their families what to watch for. It could be grand mal or petit mal, like we talked about a couple weeks ago. Okay, so that's it with head injuries. I want to move into spinal cord injuries now. Your biggest age group of people that are at risk for spinal cord injuries are young males between the ages of 16 and like 29, because most of the time a spinal cord injury occurs because of something that could be prevented, or an accident because somebody was doing something high risk. So we see it a lot in like skiers who are out doing all those tricks and flipping up all over the place. Motorcycle riders, people that young kids are climbing up a tree and falling off a roof or out of a tree or something. That's the number one reason people get spinal cord. Divers who are diving into shallow water and they snap their neck. And those tend to be the higher risk takers, which tend to be males, young males. So education and teaching is huge. If you're working in community health, you're going to want to teach your young adolescent males to be careful, to wear their seatbelts at all times. I do want you to understand the pathophysiology of spinal cord injury. So I'm over on page 2010 now, and look under this section of pathophysiology. The part that's important to know, and we're going to go over this in a minute, is which vertebrae is damaged, and it will result in what of the following sequelae. So we're going to talk about that a little bit more. In a spinal cord injury, you tend to have paraplegia, which means inability to move like from top to bottom, and you identify the level of the injury based on sensation or movement below the level of the injury. So you would say, say if somebody has a C5 injury, it's probably up here, and they will not be able to move or feel anything below the level of C5. So that's sort of how they determine it, and it's based on neuroexam. You just touch somebody, can you feel here, can you feel here, can you move your fingers? And based on that, you can tell what level of injury they are. They probably will also get a CT scan or an MRI. You don't need to know this big chart on page 2011, chart 6 to 8-7. you don't need to know about that specifically. Those are very, very rare in the world of spinal cord injuries. But just be aware that there's something called central cord syndrome, anterior cord syndrome, and Brown-Séquard cord syndrome. Those, all three of those are types of spinal cord injuries that just impact a portion of the spinal cord, like this way. And it's weird, the manifestation is weird, because like they might be able to move some parts and not feel other parts. So I'm not going to confuse you with that right now. So paraplegia is inability to move top to bottom, whereas hemiplegia, like we talked about with strokes, is inability to move like a right or a left side. So hemi is this way and paraplegia is this way. So that's just words you need to know. Okay, this table 68.3 on page 2012, I'm not going to go through every single one of these, but you need to know this table. It's really important to know if somebody sustains an injury, at what level, what can you expect to see as a nurse. If somebody's injured at C1, they probably died at the scene, because a C1 is very high. It's just right underneath, you know, where that brainstem is, very high. And unless somebody's sitting there with an ambu bag, the patient will not be able to breathe. They will have absolutely no sensation after that. So, you know, it's possible that somebody can survive a C1, but that would be if somebody got to them and could get them on a respirator like stat. Between the levels of C2 and C3, they will be on a ventilator, because that wipes out their diaphragm, and so they can't pull their diaphragm down, they can't get oxygen in, they're going to need to be on a ventilator. Patients at C4 might be able to have some diaphragm movement. Although it's going to be weak, they're not going to be able to expand their lungs, so we're going to be really careful with patients who they get their pulmonary problems. They get pulmonary infections. They can't expel air very well, so pulmonary issues become big in patients with C4. And then all the way down. And the lower you go in the spine, the better. So make sure that you're looking through that table. If you're working in the ER or as out with the paramedics, or if you are a paramedic or an EMT, you'll already know this, the most important thing is to stabilize that spine, because what they're finding now is that the initial injury is one thing, but then secondary and subsequent injury can actually make the injury worse. So for example, if that spine is severed or sheared and there's bone fragments, if you're not careful with that spine and that bone fragment goes in and shears off some more of that spinal cord and you've made the injury worse, that's not a good thing. So you want to maintain head alignment, get them in a cervical collar. You as a nurse, if you're working in the emergency room or in radiology or something like that, you do not take that cervical spine off until you can clear C-spines. They will go in and they'll x-ray and make sure all of those C-spines are intact, and then you can take the collar off. Now you just have a head injury. But if they do find out that there is a fracture at one of those vertebrae, then they will repair that, and then they keep the patient on steroids. Although some of the steroid stuff is getting a little controversial, the studies now are showing that that might not have as positive results as we thought. A lot of centers still put somebody on steroids to try to decrease the inflammation at the site of the injury. Then if they find out that the patient does in fact have a spinal cord injury, then they will put the patient in traction. And a picture of this is figure 68.8 on page 2014. That guy is in what's known as a halo traction, and it would be the same thing as like putting another bone in traction, and we'll talk about this during ortho week. But what they do with this halo, it's quite the contraption. They basically screw with actual screws right into the head. They put this halo, a metal halo, into the head, and then attached to the halo are these bars that come down, and you can see it onto this chest cast. So, and what that does is then the patient can't move, so they're going like this, and it keeps that spine completely in alignment while that spine is healing. And so somebody usually has to be in that, 6, 8 weeks, 3 months, depending on the severity of the of the injury, but that's traction. And they keep somebody in that while the patient is recovering. So immediately after spinal cord injury, two things can occur that you need to be aware of as the nurse. One is spinal shock, and the other one is neurogenic shock. You probably, hopefully, talked about neurogenic shock in MedSurg 1 when you guys went over shock. There's 5 different kinds of shock, and as you know, shock is basically inadequate tissue perfusion. There's not enough oxygen to the tissues. Neurogenic shock can cause that, but neurogenic shock shows up later in a spinal cord injury. Spinal shock shows up early in a spinal cord injury, and it's associated with a sudden depression of the reflex activity. So you're not going to see any reflex activity below the level of the injury. And so you're going to see things like bladder distension, bowel distension, so you get paralytic ileus, the gut just stops. You know how the gut normally is supposed to move? Well, it's not moving, so it could cause a paralytic ileus. This can occur very quickly, within 24 hours to a week of the spinal cord injury. Then, sorry about my dog. Then neurogenic shock. Neurogenic shock happens because of the loss of autonomic nervous, and specifically the sympathetic nervous system. So if you remember, the sympathetic nervous system runs down the spine, and exit is at the level of T7 or C7, comes out at C7. So the sympathetic nervous system is responsible for slowing things down. So if you have an injury above that level, then your patient does not have the sympathetic nervous system to counteract the parasympathetic nervous system. So if somebody starts developing neurogenic shock, everything like their blood pressure will drop, their heart rate drop, their cardiac output starts falling down, the venous pooling starts occurring because of vasodilatation. So basically what's happening, that's why the other organs are not getting perfused, is because there's just massive vasodilation. And when there's certain things that can cause that. It can occur at any time following the spinal cord injury, so that's something you have to be aware of in your patient. And you want to detect this early. You want to suspect that it's happening early, like when fever comes on really quickly can be one indication, so you need to be careful of that. The other thing I wanted to bring up is autonomic dysreflexia. Autonomic dysreflexia can occur in any spinal cord injured patient, and it can be an emergent, life-threatening development. What happens in autonomic dysreflexia is it is an exaggerated response to something that a normal person is aware of. For example, a full bowel or a full bladder, and a person who can sense that, you can go take care of it. You would relieve yourself, eliminate. But in a spinal cord injured person, they can't detect that. They can't feel those senses. And so in autonomic dysreflexia, what happens is your patient will all of a sudden get massive vasodilatation above the level of the injury, and they'll get very flushed, they'll get a pounding headache, they'll get really high blood pressure, they're sweating, profuse sweating. If those things start occurring in your patient who has spinal cord injury, they're having an autonomic dysreflexive or hyperreflexive response, and you have to eliminate the cause. So if your patient starts developing all those symptoms I just mentioned, figure out if there's a trigger. straight cath them. If they have a catheter in already, maybe it's clogged, or maybe they haven't, produced any urine output. So figure out is that clogged? Is their bladder distending? Do they have? Are they impacted? Do they have a fecal impaction? Do I need to get rid of that? Are they developing an infection somewhere? Are they in pain? Any little thing could possibly cause it. And if you can eliminate the cause, you can bring that blood pressure down, bring the heart rate down. They'll usually tend to the diaphoresis will stop. But if you don't stop that, they could have an intracranial hemorrhage, because the blood pressure in their head can get so high it can rupture those vessels and becomes a life-threatening situation. So you want to make sure that your patient, pressure ulcers can cause it, pain can cause it, so be really careful about how to recognize autonomic dysreflexia and what it is in your patients who have spinal cord injuries. Autonomic dysreflexia will not occur until spinal shock has resolved, and spinal shock usually resolves, like I said, within the first week, sometimes 2 weeks following the injury. So if you're working with the patient for the first week or so, they're not going to have autonomic dysreflexia. If you're working in the rehab unit and you're working physical therapy and helping them with contraction stuff, now you got to be worried about it. Okay. So now, depending on where the level of the injury is, once you get them stabilized, and once they're through that acute phase, now the bigger nursing problem becomes rehab and lifelong health, because now everything is going to get much more difficult. So you want to improve mobility as much as possible. If they don't have a complete spinal cord injury, if it's just an incomplete spinal cord injury, that's best. And then you can slowly try to regrow those nerves. Nerves grow very, very slowly, 2 millimeters a year. But with stimulation and with working, you want to keep those muscles moving. You want to keep them in rehab. You want to prevent contractures. You want to encourage lots of protein, lots of calories, because protein restores tissues and muscle as it's healing. You may have to teach them, if they're paraplegic and they have good use of their hands, they need to be taught how to do intermittent straight cath. They may have to straight cath themselves every 4 hours. They may have to do rectal stimulation every morning to get them to have a bowel movement. In some patients where that's not possible, urostomies and ileostomies, might be more beneficial than, if they are unable to straight cath themselves, or they don't have anybody to help them with that. The other thing with patients who have spinal cord injuries is, what was I going to say? I just lost my train of thought. Oh, home care. Did I say, what level did I say when I told you to watch for patients with autonomic dysreflexia? Did I say C6 or T6? I hope I said T. T as in toy. So the autonomic dysreflexia, because the sympathetic nervous system will come out at T6, toy 6, not cat 6, come out at T6. So anybody above that is at risk for autonomic dysreflexia. Hopefully I didn't screw that up. I'm pretty sure I said T, but anyways, T as in toy. Okay. Let's see, what else do I want you to know about? Okay, so long-term spinal cord injury care, they are, oh shoot. Oh, hang on a second. Shoot. Hey, can I call you right back? I'm lecturing. Give me 2 seconds, I'm almost done. Okay, bye. Okay, so read through this part, medical management, long-term complications of spinal cord injury. Spasticity is a huge problem, and it's very painful for patients, because they start getting, have you ever had like a muscle cramp or something in your leg, and like it cramps up really hard at night? That's what it's like for patients who have spinal cord injury, so it's really, really painful. So you want to prevent spasticity. There are some medications that can help with that, and also just, really good range of motion and contracture prevention will help with spasticity. Anyways, there are some meds, and it's over on page 2023. You can see some of the medications for spasticity. Coping mechanisms, sexual expression, especially if they were married or they're hoping to get married, because remember I said, I mean, this is the age group where men are, thinking about having families or getting married or something. So there's a lot of options for men. Can still have children. Women can still get pregnant following spinal cord injuries. It's not the same way that that other people may, but that they can still have that as something to discuss with your patients. And then home care. Most people want to go home and, maintain their life at home. There's all kinds of things available for people who have to be in wheelchairs. There's all kinds of ramps. There are cars that have hand controls for people who are paraplegic. So there's all kinds of things, but it takes usually 1 to 2 years from the actual injury to figure out where the person is going to be in a recovery standpoint, and then from that point on, just a couple years to fully being able to integrate back with society. It requires tremendous amount of nursing care, nursing resources, healthcare resources, family coping. So there's a lot involved with somebody who has both head injury and spinal cord injury, because the nature of the injury creates either a different person cognitively or motor sensory. So lots of implications for head and spinal cord injuries. So okay, so read through that, and then when we come back next time, we will do chapter 29 with the autoimmune disorders. Okay, see ya.